you want to have control of it, or I don't know how that works?
Yeah, you can do it. It's fine.
Okay.
And then also just to go what Joe was saying, we don't really have any poll questions this week, so we're going to be asking for more participation. If able, that'd be great. All right. So this is case 1. Joe didn't want to go first, so I'm going to go first. So this was a 20-year-old male. He came in after a motor vehicle accident. Most of the trauma we see tons of MVCs, tons of motorcycles, tons of penetrating trauma from gunshots. So this is a normal case for us. This guy came in the trauma bay with leg pain. You get a call from the trauma team that says like, hey, this guy has a femur fracture, leg pain, past medical history, past social history, all this is negative. You can go to the next slide, Joe. So they get these x-rays. Does anybody want to volunteer about going through what they see on the x-rays? If not, one of our residents can go through it.
I can give it a shot if that's okay with you guys.
Oh, yeah.
So this is what looks like a AP and a lateral of a left femur, demonstrating a mid-shaft, I would say roughly transverse fracture of the femur that is probably like 6 centimeters shortened, and the fracture has fallen into a little bit of, I think, varus.
Yeah, so you brought up a lot of great points. So agree with you, it's relatively transverse. You said it was short. You mentioned that it was mid-shaft. We don't have a whole femur. So it's, if we gave you a whole femur shot, it's a little bit more proximal to that. If we measured it, it's probably about 7 centimeters from the lesser troch. So it's more proximal, or you can consider it a subtroch femur fracture. You said it was short, and do you see any other type of deformity on there? What do you see on the lateral?
So it also looks like the distal aspect has kind of subluxed posteriorly as well.
Mm-hmm. But if you look at the lateral, if you look at the proximal fragment, would you say it's flexed, extended?
I would say it's flexed.
Yeah. So most of these, so we would consider this a subtroch-like femur fracture. I'm saying like because a subtroch is characterized as 5 centimeters from the lesser troch. And if we measured it, it's probably a little bit more distal than that, but it's acting like a trochanteric femur fracture in that it's going into the normal deformity pattern that we see in subtrochs. Joe, go to the next slide. So these are the normal deforming forces. So you see flexion of and so normally when we talk about displacement of fractures, we're talking about the distal aspect of the fracture. But for subtrochs, for some reason, we talk about the proximal, what the proximal fragment's doing. So it's always in flexion, external rotation, abduction, and shortening. So can someone just go through, what do you think the deforming forces are that's causing each of these, the flexion, external rotation, abduction, and shortening?
I'll take a stab at it. For flexion, I think it's the psoas. For external rotation, I think it's the short external rotators. For abduction, I think it's you have your tensor fascia lata, abductors like that, and then shortening.
So the shortening actually refers to the distal fragment.
Oh, the distal, okay. You have your
So what do you
your,
think?
your flexors, not your flexor, your knee flexors. So like, I'm thinking like rectus femoris, vastus intermedius, vastus lateralis, those muscles.
Yeah.
Nice. So your knee extensors will help shorten. Anything else?
What about behind?
Hamstrings as well. Biceps femoris, semitendinosus, semimembranosus.
Nicely done.
Yes. So Joe, you can go to the next slide. Someone else want to go through this?
So just for the sake of time, we'll just sort of reiterate. It looks like you hit all of the right stuff there. The iliopsoas flexes the proximal fragment. You have the short external rotators, but the iliopsoas, additionally, because it's inserting on a posterior structure on the femur, the lesser trochanter is posterior. So when it pulls it up, it's externally rotating as well as flexing it. And then your abductors, your gluteus medius, your gluteus minimus, and certainly the tensor fascia lata is contributing to that somewhat as well. But the majority of the abduction would be coming from the glute muscles, and then quads and hamstrings you fit very nicely.
Yeah. So when you get called from the trauma bay, what do you guys want to do next? So what are you looking at on your physical exam? Can anybody point out certain things you want to see when you go examine the patient?
Can I go?
Sure.
So you want to inspect first. You want to get an idea of the global picture of the patient. You want to make sure that you're not missing any other injuries. Do kind of a global review, then focus on your examination of the injured extremity. We talked about some of those deforming forces, and so appreciating that you're seeing the leg. We talked about a little bit of shortening, a little bit of flexion of the proximal fragment, some external rotation typically at the foot. And if you don't see that, right, that should click in your mind that there's maybe something else going on. So keep that in mind. That's a good kind of way to think about it, I think, is just making sure that what you're seeing clinically is consistent with the x-ray. Then you want to inspect, make sure there are no open wounds. You want to palpate, make sure that you're not feeling any gross deformity elsewhere, and get a good neurovascular exam. And especially for these, you want to get a good, at least on palpation, examination at the knee to make sure there isn't any other injuries that you could be missing.
Yeah, you have to remember that a femur fracture requires a amount of energy. So this is something we definitely refer to as a distracting injury. So you definitely want to start your examination all over the other extremities before you move to the injured extremity to make sure you're not missing something, whether it's a forearm fracture, something in the hands or feet. Make sure you're taking care of the whole patient.
Yeah, our institution, I would say it's routine to get ABIs, ankle brachial index. I don't know if that's everyone's protocol at all institutions, but for us, it's a good one to go by.
Pretty good literature to support using ankle brachial indices in femur fractures and long bone, lower extremity, high energy fractures. I think that most trauma centers probably do use them. It was classically described in fracture dislocations of the knee, but there have been multiple papers which have supported the use in other areas. And I don't know, I haven't been at other centers, but I think it's become pretty standard.
Yeah, I'll pretty much get it from anything from a subtroch down to distal tibia.
And the reason we say that ankle brachial indices, so in a patient, in medical school, you learn about ankle brachial indices as a way of looking for peripheral vascular disease and looking at how much blood flow there is to the foot. In trauma, it has been found to be a very sensitive indicator. In a patient who you think their blood vessels are otherwise normal, you would expect that the ankle brachial indices should be close to 1. And if they're reduced and we use less than 9 as our cutoff, that is a pretty sensitive indicator that there may be a vascular injury that should be looked into more closely, typically with some sort of angiography, whether through a direct angiography or a computed tomography angiography.
I mean, most of the time, if it's a reduced ABI, it's the patient's in vasospasm, but it should be worked up further in case there is more serious, stuff going on. So I think Joe hit on pretty much all the stuff that's listed here. So you can go to the next slide. So the additional trauma workup's negative. So it's pretty much just a 20-year-old guy with a left subtroch femur fracture. What do you guys want to do next? Is there any certain things you want to do in the trauma bay? Do you want to splint them a certain way? Do you want to do any additional intervention in the trauma bay? Do you want to just rush them up to the operating room? Do you want to send them home? Anybody have anything to comment?
You want to say what time it is, Jeremy? You want to give a time of the day that this happened?
It's 5 o'clock at night.
It's right now.
7:21 p.m.
I think I would maybe lean towards doing like a traction pin and just at least like pull that back out to length. I don't think, given the time of day, like taking him to the OR is necessarily like emergent unless there's something like it's an open fracture or there's, decreased ABIs or some type of, distal neurovascular compromise that would kind of be like a red flag.
Mm-hmm.
Nice.
Good. I mean, it's a good answer, Ricky. I think, you're going to be able to get, if you can potentially get this fracture out to length, you're going to improve their pain control. You're going to allow those muscular forces to relax. It may potentially improve your, make the OR go a little bit more smoothly, but most importantly, it's to help get your patient out of pain, get them comfortable. Is there any other imaging other than this femur x-ray that you want before you do traction?
I would probably have one joint above, one joint below. So I'd probably want to go include like full femur and then go probably all the way down to the ankle, and then also make sure I'd get like pelvic films.
Okay, yeah. I think I was going for knee x-ray, but I think your protocol is absolutely perfect.
We have a question in the chat. Lisa is asking if we ever got a CT of this. Lisa, do you want to clarify what you want to get a CT of and what you'd be looking for?
If not, it's no pressure. I think that a CT scan is certainly, Jeremy, do you have a slide, any related to a CT scan coming up?
No, not, I thought you would touch on that, so.
Yeah.
Sure.
Okay. So she clarified that she would be looking for extension of the fracture, which is definitely important. Again, we see that this is a fracture through the femoral shaft, but you are concerning if it extends proximally up towards the peritrochanteric region.
Yeah. So I don't have a dedicated slide on this. It was going to be just a talking point. So now is as good a time as any. So in high energy femur fractures, as to be distinguished from atypical femur fractures, or someone who has cancer that's weakened the bone, someone who was in a car crash or something like that and they broke their femur, there is an association of patients also breaking their the proximal femur, their femoral neck. So for the fracture itself that we could see there on the x-rays, I don't think that a CT scan would necessarily help you in terms of management or helping you figure out what you're going to do to fix that particular fracture pattern. However, it has become standard in many institutions. It's not by any means gold standard, and it hasn't been established as such, but many trauma institutions will get a CT scan of the pelvis with thin cuts through the femoral neck to make sure that there's not an associated femoral neck fracture. Some places still go a little bit of a more old school route, which I think is still somewhat reasonable, of just examining the femoral neck very closely in the operating room with careful fluoroscopic views and even taking the hip through a range of motion under fluoroscopic views. But if there was a femoral neck fracture, it would be nice to know about it before you started your surgery.
Yeah, so I think Joe touched on this, Ippolito, that before you put in a traction pin, you should get an x-ray of the location that you're going to put the traction pin in to make sure that there's no additional fracture or anything, any pathologic lesion there, so that you're not going to cause any further damage to the patient. In our institution, whenever there's a femur fracture, we'll put in proximal tibial traction. I know at some other places they'll do distal femoral traction still, but we'd like to exclude the bone of interest so that there's no further involvement of that bone. So you can go to the next slide, Joe. And so pretty much what Ricky was saying, we're going to put traction to pull it out to length, and you can see in this image that shortening that was there previously is now lessened. There's still a little bit of shortening, but it's a lot less than the initial x-rays that we obtained. You know, the next slide. So does anybody have any ideas of what type of treatment options, what do you guys want to do for this patient?
You could do a nail.
So yeah, there's, I think a nail is a great option. There's a couple different types of nails. You can do a intramedullary nail or a cephalomedullary nail. So you can either put just a screw up the femoral neck, that's a cephalomedullary nail, or just some interlocks proximally. And then there's also entry points that you can think about, either a piriformis entry or a trochanteric entry. Do you have any thoughts about which you would want to do, or why you would want to do either of those? You also have a retrograde femoral nail versus an antegrade femoral nail.
Piriformis, I know, is it's like more in the trajectory of the axis of like the femoral shaft itself.
So what would that help you with?
Then you wouldn't have it wouldn't cut out of go through either cortex, I guess. It reduces the risk of that. That's what I thought.
I mean, it would just reduce your risk of causing another deformity once you put your nail down. So you're 100% right that starting point of your piriformis fossa is in line with your femoral shaft. So if you're going to get a starting point there with a relatively straight implant, then you're not going to cause a deformity. If you went with a trochanteric starting point, that starting point's a little bit more lateral. If you still, the nails are designed to allow for that, so they have a little bit of a lateral vector to allow for that, but they can still cause a little bit more of a deformity rather than a straight shot down from the piriformis down to the femoral shaft.
I think the trochanteric, the abductors are spared more than in the piriformis. Is that another?
So yeah, I think that with trochanteric start points, there is some risk of detaching part of the abductors, but you do also go through the abductors a little bit for a piriformis start. The main reason that at our institution we would choose a piriformis start would be mostly because it's straight in line, and once you have your reduction, it's much less likely to lose your reduction, and sometimes it can actually help you in gaining your reduction. But it's not wrong. There are definitely places and surgeons who get good outcomes who would do a trochanteric start for this. It's
Guys, oh, go ahead, Joe.
nope. I'm done.
I wanted to kind of gauge your thoughts real quick on something that came up in the chat. Someone had said about if this fracture was a little bit more distal. Now, we had addressed that there was no involvement at the femoral neck here, right? And then my headphones died for a little bit, but we're talking about this fracture. Somebody had mentioned if the fracture was a little bit more distal, they would want to consider a retrograde nail. I wanted to pose to you guys, can you use a retrograde nail? Talk about maybe if we can touch briefly on some facts about retrograde nail and then differentiating that from preferences.
So
Joe, Jeremy.
Let's save that talk for the transition of cases.
Oh yeah.
We're gonna talk about a nail that may or may not go one certain direction in another case coming up.
All right, Lisa, stay tuned.
All right, you can go to the next slide, Joe. So in this case, we decided to do an antegrade femoral nail, exactly like Kay was saying, piriformis starting point. And we use a Synthes nail in this case. You can go to the next slide. So here we got our piriformis starting point. And you can note that in this case, it looks, if you look on the left on the AP view, it looks like your starting wire is posterior or in the bone, but this is actually posterior to your neck, Joe. If you can use your
Yeah, trying to pull it up.
And kind of show where the neck is. The piriformis fossa is posterior to the neck. So when you get your starting point, it looks like it's in the bone, but it's actually posterior to the neck. If you're up on top of the neck, then you're too anterior and you have to move your starting point posterior.
Where? Oh, I see.
That's a really good point, Jeremy. That's something that you always see intraoperatively and you kind of question.
This shadow here looks like the top of the bone. And why is the tip of the wire way down here? Well, the explanation is over here on the lateral. If you look at this little recess here, you can follow the trochanteric profile around. It comes down here. And then over this way is the intertrochanteric crest. And this area right here is what is anatomically known as the trochanteric fossa. And surgically, we call it the piriformis fossa. And that's the place that we go and we call for a piriformis start.
All right, you go to the next slide.
Okay.
So then once we got our starting point, we passed our wire, and then we got this X-ray here. And so we're trying to pass our wire to the distal fragment. And can you tell for certain that this starting wire is in the distal segment? And if you go, the answer is no. And if you go to the next slide, Joe, you can see that it may be looking good on one X-ray, but you have to confirm on the lateral. And so we have an attending that says one view is no view. And so you have to get two views to make sure that you're in the correct area. You can also use, in this case, tactile feel, because you can feel the cortex with your guide wire to see if you're in the bone. So in this case now, we have a proximal fragment that's flexed, and we're trying to pass our guide wire through. There's a bunch of different ways that we can do to manipulate and better reduce this fragment. Do one of you guys want to talk about different ways? There's, if you go to Joe, if you go to the next slide, there's a bunch of different ways to go about it.
All right, so Jeff, you want to talk through some of these?
Yeah. So if we're talking about how we're going to reduce the fracture, keep in mind that we're...
Joe, can you, Jeff, unmute your...
You're muted, bud.
Sorry, guys.
You guys can't read lips?
So in order to reduce this fracture, we have a couple options. Keep in mind that the wire is coming from proximally to distal. So the fragment in the top right is our proximal fragment. Down at the bottom left is the distal fragment. In order to reduce it, we essentially need to try to neutralize the deforming forces we were talking about before. In terms of our close reduction tools, you can place bumps, or sometimes if you're using a fracture table where there's no real bed underneath the distal leg, you can use a crutch that is sterile or that is non-sterile underneath the drapes to help put a anterior directed force over across the distal fragment to help reduce that. Additionally, you can use manual force where you actively push down to extend the proximal fragment, trying to meet bring the fracture edges together. The finger tool is something that is in many of the devices, many of the trays, where once you have your opening reamer in the proximal fragment, it's essentially a levering tool that you can use to help control your proximal fragment. In some cases, particularly if you have something that's a little more accommodated, or additionally, if you have a butterfly fragment or something that you can get a good fracture read, you may do an open reduction through a lateral approach. You can use different tools to essentially either reach to the medial aspect of the femur and reduce the fracture on the AP deformity. And then you also have clamps that are either collinear or Weber, Weber clamp to help align the fractures so you can pass your guide wire down to the distal fragment. Again, at the bottom, you can see that you do have different positions for the fixing this fracture. You can see people do it supine, and additionally within supine, you can be doing it on a fracture table, which will pull traction for you. But again, then the leg is suspended, and you have different deforming forces versus supine on a flat table, where you'll need multiple assistants to help reduce the fracture, versus some surgeons prefer a lateral approach that can help aid in getting your starting point, particularly for a piriformis nail, because it will force the leg into adduction that will help you get immediately around the greater trunk for something like a piriformis start point.
Yeah, those are all excellent points. And we've come up with all of these innumerable ways of helping us reduce the fracture because each fracture is unique. Where it's located is the determining factor of what muscular forces will be putting each fragment into what position, and the morphology of the fracture itself. Here we have a transverse fracture. If we were to do a small open approach, this one would be very difficult to help us reduce it with a clamp, like a collinear clamp or a Weber clamp, just because the place you would want to put the tines for that, they wouldn't help you realign this. Putting two little joysticks in the bone would be much more useful here to be able to steer the fragments and just line the bone ends up.
Yeah. Joe, what are you going to try first?
I think for me, the first thing that I would try is a full close reduction. I wouldn't try to violate the bone or do an open approach unless I had to. I really enjoy, I think the finger tool is an excellent tool, and it works best for proximal fractures. It's basically just a steering rod. It's like, depending on the brand, 7 or 8 millimeters, and it's much stiffer than the guide wire. So once you've opened access to the medullary canal with your opening reamer, you can place this rod down over your guide wire, and it has enough rigidity and enough stiffness that you can actually manipulate that fragment, almost like you're using your finger to just guide it in space. Once you get past the isthmus of the femur, though, once you're kind of beyond a mid-diaphyseal femur fracture, the finger becomes kind of obsolete. You're not going to be able to work it down that far in order to manipulate fragments. But I think the finger could be very useful in this particular one. If I could not, I think I would have a very low threshold for using the finger. I probably wouldn't try very much without it, maybe 1 or 2 attempts, but it's percutaneous. It doesn't violate any tissues that we have not already violated. So I would just go ahead and use it.
Yeah, no, I agree with you. I love the finger. I think it's very useful, and it allows you to get a close reduction rather than opening it up. Because with opening up, even if you're going to make a small incision for a collinear or Weber, you're still violating some vasculature to that area and potentially disrupting some blood flow to that fracture site that you're trying to heal. And then Shannon in the chat just asked about if we're going to keep traction in the OR table. Jeff kind of answered already in the chat, but we take traction off. We leave the traction pin in, and we keep it in there so you can pull manual traction through your traction pins in the operating room. If you keep the traction on, the problem with that is you're going to keep that same vector of the traction. A lot of the times you have to adduct and bring the leg in to get a better starting point, and also help counteract your deforming forces. So if you leave just a normal traction with the weight on, you can't do that. So we do manual traction once we're in the operating room.
I think it's important to state that doing this with a fracture table is completely reasonable, and it's also dependent on the number of team members you have, the comfort of your surgical staff, and dealing with the fracture table and helping you make those adjustments. It's still definitely a reasonable option, but it's just, we typically do what Jeremy described at our institution.
Yeah. All right, go to the next slide. So yeah, in this case, we did it closed. We used bumps. We used manual force. You can see here, instead of using your hands, you can use mallets to reduce your exposure to fluoro. So we use a mallet to reduce the fracture, and then we were able to pass our guide wire. You can go to the next slide. Once we get the guide wire into the location we want, we ream it. Usually about 1 to 1.5 greater than the nail that we want. Go to the next slide.
Hey, Jeremy, right here before we move on, why did we just go to all this length? Why did we reduce it? Why didn't we just sort of somewhat align the bone and get the wire across and then just keep going?
We want to reduce it in the location, or the anatomic location that we are going to ream it, because once we pass our reamer is going to go and cut out bone in that area. So we have to make sure that it's reduced, because once we pass our reamer, that's going to prevent additional deformity. If we're not reduced when we're passing our reamer, then we're going to ream out additional areas of the bone that we don't want. And then once you pass your nail, it's going to follow that area of your reamer. Yeah.
So you're forming a path that bone is then going to, that nail is then going to occupy. And if your path is in an abnormal trajectory, then the nail is going to reproduce that. So nails don't reduce fractures, they hold reduction. They stabilize reductions that have already been obtained.
So these are just our post-op x-rays. We can touch on some other points later if we have time, but you can go on. So this was going to be a question, what type of fracture healing and bone stability? If someone just wants to jump in and answer the question, or if one of the residents just want to go through it real quick.
Talk about coming full circle. Maybe one of our students can ask. It's from early on.
I know. I even included one of your slides.
I think this would be secondary.
Go for it.
Sorry.
No, you're good. Go for it.
I think it'd be secondary bone healing with relative stability.
Nice. And why do you say that?
Because of the rod construct, it still allows for enough motion that you're still going to form a bony callus, but it's stable enough that you're likely not going to have a NAL or non-union with it.
Awesome.
Excellent.
Yeah, so you can go on to the next slide. I only have 6 weeks follow-up on this patient, but as you pointed out, you're looking for callus, and you can see that this patient's already forming a little bit of callus. So, and if you just go to the next slide, this is a little summary of what Joe was saying. We touched on, I think, on week 2 about different bone healing and stability constructs. So.
All right. So since Jeremy had his labeled as case number 2, I decided to label mine as case B. So this one we'll kind of move through a little bit more quickly and maybe sort of just present the case. And if there's, we can certainly stop at some points and go through some excellent talking points. But you know, I put a bunch of pictures in here, so it'd be nice to maybe we can go through this. So we have here a 48-year-old male. He was in a high-speed motorcycle crash versus a car, and he presented in an altered mental status. He had a Glasgow coma scale in a range of 11 to 12, and he had significant facial wounds as well as a very visible, obvious, gross left lower extremity deformity. He came in hemodynamically stable, and he had a high blood count with hemoglobin of 16. But he was emergently intubated in the trauma bay in order for airway protection because he was bleeding and he had an altered mental state, and he was at a high aspiration risk. So in a standard trauma evaluation protocol, we follow our ABCs. We go through airway, breathing, and circulation. And so we're evaluating the chest, and we're evaluating after he's intubated. And we can see that he actually has some effects from pulmonary contusions. He has a little bit of pulmonary congestion from the injury burden that's happened. And we get a pelvic x-ray in patients who cannot be taken quickly to the CAT scanner. A pelvic x-ray is a standard protocol for evaluating patients of high energy trauma. And right off the bat, I think if we look at this, let me see if I can find my laser pointer again. We can see several things that are going on here. And although the object of this talk is not to talk about pelvic fractures, it is part of the talk to discuss how other injuries affect what we do. So here we can see that we have rami fractures on the left, superior and inferior, and the inferior ramus here is comminuted and segmental. We have ramus fracture on the inferior pubic ramus and superior pubic ramus, so we're bilateral now. If we have injuries to one part of a ring type structure in the front, it's very likely that we also have injury in the back. And in fact, if we look back here, we can see that there's significant widening of the sacroiliac joint. And I think that you can appreciate that there's a fracture line that comes across here as well. And then on the other side, I think it's a little difficult to see on this screen capture, but I think that you can appreciate that there's widening at the caudal aspect of the sacroiliac joint and a fracture that goes straight up all the way through the sacrum. So we have a significant pelvic injury in this patient, and we're returning to our deformed left lower extremity. And here in a spot injury film that we get in the trauma bay, it's very typical that we get images that are either obliqued or only part of a bone or one view of a bone. So we have to try and put together as much information as we can from what we get. And if the patient is stable enough, we'll get more information later. So here we can see that we have, in discussion of high energy femoral shaft fractures, we're trying to evaluate the entirety of the bone. It's very obvious what we can see down here that we have a very comminuted femoral shaft fracture in the distal half of the shaft. Trying to look at the rest, there's not an obvious femoral neck fracture that we can see here. The calcar contour appears to be continuous. We can still see the shadow of the piriformis fossa. We can see the shadow of the greater trochanter, and we have a good outline of a femoral head. So this gives us some reassurance, but it's still something that we want to pay close attention to. We got a little farther down, and now we can see in the distal aspect of the femur that we have fracture lines which appear to be going farther down, like down towards the knee joint. And now we have to start wondering, is this more complicated? Is this more than just a, because it would be nice if we could just say that, okay, it's broken here, it's comminuted here, and it stops here. We could just ignore all of this and just put a nail in. But with this fracture line running down more distal, now we have to wonder, is this an articular injury? Is it more than just a diaphyseal or a long bone fracture? On our lateral x-rays, we can again see the deformity of the distal femur. It's falling into a posterior angulated direction, or a recurvatum. It's significantly comminuted. If we were to try to enumerate these, we have 1, 2, 3, 4, 5, 6, 7 fragments that are visible on plain radiography on the lateral. And again, we can see this fracture line that appears to be propagating distally. And now I want to ask, I guess I'll pose this to Jeremy. When you have distal femur fractures and you're worried about fractures going into the joint, what patterns are we talking about? And there's a significant talking point here, which we talk about at our institution, about what plane the distal fractures are in and which ones are easy to miss. What's going through your head right now?
Yeah, so once I see something going towards the joint, I'm going to get a CAT scan to further delineate the fracture pattern. But you often miss a Hreha fracture, which is in the coronal plane, because it's going to be in the plane of this x-ray that you might not be able to see. So it was written up at Harborview that I think it's about like 30-40% of the time they're there with distal femur fractures.
Yeah, so one thing is there's a certain way of learning orthopedics, which is studying anatomy and studying things that we see. And then we supplement that with the experiences of other people, and we read the literature as much as we can. And when people smarter than us recognize a pattern that's very common, now we know to look for it and we're more likely to find it. So on a very perfect lateral x-ray, which the junior resident on call held for this and got a perfect x-ray, I think that you can see this fracture line, which is going right here. And that's in the plane that you almost can never see this on plain radiography, but we were very fortunate to see this one. We would have picked it up later anyways, because for this, how high energy this is and how close, and we already saw in the AP plane that there was a line going down, we would have gotten a CAT scan anyways, but this is just a nice x-ray that shows a Hreha fragment. Okay. More perfect x-rays because someone diligent. Well, this was actually, this AP was taken. So this is a nice talking point. In these patients, we have a patient who we know has a head injury. We know that he has some amount of a chest injury, and he has multiple musculoskeletal injuries, a significant pelvic fracture, and a very bad femur fracture. His body has taken a significant beating. We don't have time to get into this talk, but it's one thing that we talk about very commonly, and which has become very instrumental in really saving people's lives, is damage control orthopedics, where when a patient is going into a negatively a downward spiral in their physiology, they're forming more lactic acid in their body. Their coagulation cascade is going out of whack. Basically, the mechanics of life are messing up, and all of their systems are going offline. They need to get to the ICU, the intensive care unit, quickly in order to be resuscitated, to be supported. They may need pressure support. This gentleman ended up needing a bolt placed by neurosurgery. So in these instances, damage control orthopedics is a way of stabilizing the bones to decrease the ongoing injury to the patient, typically done with an external fixator, sometimes done with other methods like a sheet that we can place on the pelvis, things to stabilize the skeleton in order to lessen further damage from happening, and then resuscitate that patient. In addition, putting an external fixator on this extremity fracture pulls the bone out to length, allows us to better evaluate it, and then we get a very nice CAT scan, which can help us make a treatment plan. So I'm hoping that this is going to work. So we have a video of CAT scan that we had here. So on these sagittal reconstructions, here we can see that Hreha fragment. So here's the fracture line going through the lateral posterior femoral condyle, and it's non-displaced. It didn't go anywhere, but there's the fracture line, and that is an articular injury you can see right here. This is all the articular surface of the distal femur, and our fracture line is going right out through there. So our treatment plan has to incorporate this, because if we were to just put a big intramedullary rod up, we're very likely to displace this and then cause articular step off, which would then lead to joint destruction. And in the coronal reformats, we can see that it's actually even more complicated than we initially thought. We have a fracture line that's coming down within the sagittal plane, entering into the lateral femoral condyle, and then it diverts and splits. And in one way, it goes towards the intercondylar notch, and then in the other, it heads towards that posterior femoral condyle. It converts into that Hreha fracture line. And so looking at this, I'm going to pose this to any of our residents who are on. What are you thinking might be a definitive treatment option for this? If no one wants to give it a go, I'll just show you what we did.
Sorry, I was away for some of it, but looking back at it, I mean, with a distal femur fracture, you can potentially nail it, but once you have something going intra-articular, you might want to try to do a lateral plate. Another option is if that intra-articular split is relatively non-displaced, you can put screws in to stabilize that intra-articular portion and then put a nail in as well. Or you can do a nail plate combo as well.
It looks like the fracture is only extending to the condyle, right? Or is it going into the notch as well?
So it goes into the notch, it comes down this way. And then here is where it converts from this sagittal fracture line. It's almost like a triplane. It switches and goes into this. It starts as an axial pattern, and then it dives down in a 45-degree towards the posterior condyle like a Hreha fragment.
Well, that's kind
but
of
I think if you guys look at this, you can see that if we ignore these articular fractures, we actually have a pretty large segment of bone that if we pretended those weren't there, we would agree that this is a pretty nailable fracture. It's not a simple one that is in the middle of the shaft. It would still require some neat techniques in order to stabilize this and hold it in position while we put the nail in and put the interlocks, but we at least have enough bone to accomplish the job.
I like corkscrew retrograde nail, unless you think you need to open it. But I think most of it looks pretty well aligned.
So what are we looking at here? What type of stability do we want to use? Are we going to plate it or are we going to nail it? X-fix has already been done. Should we cast it? We'll just take that right off the table. So much like Jeremy's talk, I'll go ahead and give you a hint that we're talking about nailing this. And so we're looking at a relative stability construct here and going for secondary bone healing. But that's for that comminuted shaft segment. What about the articular segment? Well, for articular fractures, we don't like secondary bone healing. We don't like relative stability, because if it moves any, it can lead to post-traumatic arthrosis. So if we're going to operate on an articular fracture, we typically try to compress it and go for absolute stability. If we're going to nail it, should we go forwards or should we go backwards? Well, here I think it's very helpful to keep in mind that there are multiple things that might be indicating one direction. Number one, we have a significant articular injury that needs some work. So we're already, if we're going to nail it, we're already going to be doing some work on the distal part of the femur. Now, that doesn't necessarily mean that you have to go retrograde. We could do work on the knee and then go back to the top and do it through a piriformis start. But it's just something to think about. But I think more significant in this patient is his injury burden, and that he has a significant pelvic injury. And this patient went back to the operating room after he had been stabilized. And so his pelvis was being operated on as well. So he was in a position that it was more facile and easier for draping and easier for OR setup and everything in order to do this in a retrograde fashion and stay away from where we were doing the pelvic work.
Joe, just to touch on what you were mentioning, I think you're mentioning that even if you had a supine position for an antegrade nail, oftentimes this is accompanied by some sort of bump that doesn't put the patient quite supine for the pelvis. Just to recap.
Sorry, I left that out. That's an excellent point. If you're going to do an antegrade nail, femoral nail, you have to bump the patient. It's virtually impossible to do it without. And you can't, this pelvic injury precludes putting a bump. You can do a retrograde nail without putting any kind of a bump under the hip. Okay, so let's talk about some very general principles in nailing femurs. We're looking at relative stability, we're looking at length, we're looking at the alignment of the bone, we're looking at rotation, and how do we achieve those goals? Well, this is a little bit different from the example that Jeremy gave, where it was a mostly transverse fracture. The length is pretty much set for us. Once we reduce it, the two bone ends are opposed to one another, and they push into one another, and they establish the length of the bone. In that situation, it's still a little bit tricky to establish your rotation, but it's certainly difficult when you have significant comminution, and you could basically spin the two bone ends in any position in space. So we have some nice techniques for trying to achieve these goals, and we know that we're not perfect at it. So in order to obtain length, what we typically do is we take a radio-opaque ruler and we lay it on top of the intact bone if we are fortunate enough to have an intact femur on the other side. This is a mirror image, so it looks like it's the left femur, but this was actually the patient's right femur. We place the ruler there. We know about where a retrograde nail would end, which would be right in this region here. So we know that that's the 4 centimeter mark on this ruler. And then we know where the end of the nail would be in the distal segment, which would be right about this region here. And so that is at 45 centimeters. So if we subtract the 2, we know that we're going to be looking at around a 40 centimeter or a 400 millimeter nail. And if we can fit a 400 millimeter nail in the other leg once we fixed it and get the ends of the nail to stop at the chosen positions, then we have reestablished the patient's length. How do we take care of rotation? Well, there are a number of techniques that have been described for obtaining rotation. The one that has been borne out in the literature as being the most reliable and the one that we use at our institution is called the lesser trochanteric profile. And so what we do to obtain that is we know a very consistent way of obtaining a perfect lateral x-ray of the knee, where the convexities of the distal femoral condyles line up with one another in the most symmetric fashion. And when we have a good lateral, we should be able to see Blumenstadt's line, and we should be able to see the subchondral density of the trochlear groove, where those align. Once we have a nice lateral of the knee, we don't move the leg whatsoever. We have to hold it very steady. And then we move the C-arm or the fluoroscopy 90 degrees. We go from the lateral position with the beam parallel to the floor. We go straight up 90 degrees with the beam pointed straight at the floor. And we take an x-ray of the hip. And we sort of focus our eyes here on the lesser trochanter, and we get an idea of what that looks like in space. And then we try to reproduce that on the other side, because if you were to internally rotate the proximal femur segment, the lesser trochanter, which is a posteriorly based structure, would slowly disappear. The shadow of it would slowly disappear. And if you were to externally rotate this segment, it would slowly come into more view and become seemingly larger. So that's what we can use as guides. Okay, so Joe wanted to percutaneously stabilize the distal segment. Jeremy mentioned putting screws in to stabilize the fracture lines that go into the articular segment. Well, we tried that. We tried pretty diligently to do this percutaneously with a small incision to place 2 tines of a periarticular clamp and squeeze this fracture line down. But you can see there's still gapping here. And I think you can see that on your screens, that there's this, it looks like this knife went down and is still splitting this open. And so we weren't satisfied that we had adequately reduced this.
And Joe, even more to that, it's, you can see it in the interarticular area as well, that it's a step off there.
Yeah. Yep. You're referring here?
Yep.
Yeah. So we were not satisfied that we had reduced this. It's certainly not enough to the point where we could put some screws in, and then when you put a reamer on the distal femur to open up the bone, there's a lot of forces, a lot of torsion that's happening from the reamer, and you're very likely to displace fragments if they're not properly reduced and stabilized. So what we ended up doing was we dissected down on the lateral distal femur, and we did a direct reduction with some Weber clamps and using that large clamp as well. We initially had to open up the fracture and clean it out, and we found that there was some tissue that had interposed there that was preventing us from reducing that fracture. So we cleaned that out, and then we reduced it, put like a jigsaw puzzle, put it together. We used some wires to stabilize it, and once we had it in position, and then we put in a couple of cannulated screws to stabilize that. You can see that this screw is headed, if you remember that Hreha fracture line was this way, so this screw is crossing it perpendicularly in order to stabilize that. And this image illustrates nicely that you have to pay attention to which femoral condyle you're looking at, because if we think that this is the shadow of the lateral femoral condyle, well, then our screw went right out the back. But in fact, this over here is the shadow of the lateral femoral condyle. And this is articular bone here. So we don't want our screw protruding out the back. We have to stop it in a unicortical fashion. We can't go bicortical with this. So that took care of one part of our fracture line, but you remember we had a fracture line that was going this way. So we stabilized that, we compressed it with a clamp, and we put another screw this way. This screw we had to be very careful about where we placed it, because we have to be thinking about where our nail is going to be and making sure that this screw doesn't block where our nail is going to need to be. After that was stabilized, we can move on to nailing of the femoral shaft. So we used a retrograde nail. We selected the appropriate start point, which is just a hair medial of the deepest part of the trochlear groove, right in the center portion on the AP and on the lateral. We had left a couple of K-wires in to keep it stabilized while we did this. And then we did our very best to reduce the alignment of the leg while we reamed it. And this image got a little out of order. Oh no, this is just the opening reamer, my apologies. So this, we went right up the middle, and then we placed our guide wire. And much like Jeremy discussed, it's important to look on AP and lateral. You have to make sure it looks like we're in here, but that wire could be out. And then we look on the AP, we can see that we're in the bone, and we've confirmed that we bridged that site. So in order to hold such an unstable fracture in a good position while we are reaming and setting up for the nail, in this one we elected to, we took off the knee spanning external fixator and we placed a femoral distractor. A femoral distractor looks very similar to an external fixator, except that it has little joints in it that can articulate, and you can move two pins relative to one another in various angulations in space. And so we wanted to use that in this case because we could put one pin in the proximal fragment in a bicortical fashion, and then we could put one pin using a clamp to choose our position. We could then drill and place a pin out of the path of our nail. We're over here medial to where our nail is going to be. And then we can use those two pins to rotate the femur and select our rotational alignment. And then we can pull the femur out to length. And we can also somewhat set our angulation and then lock it all in place. So that then much of the work is done and we only need to stabilize it with the nail. So once we had our pins in, this is when we obtained a perfect lateral of our injured knee. And then we went up and we obtained an x-ray of the hip, and we tried to make the rotation such that the lesser trochanter matched the shadow from the prior one. It's not perfect, but we know that we're in the ballpark. So then we can stabilize it there and do the remainder of our work, knowing that we can make final adjustments at the end. So we passed our guide wire, we got up to the place where we wanted it to stop. We passed sequential reamers in much the same fashion as Jeremy discussed. And then we passed our nail. Here we wanted to end our nail exactly at the chosen location where we made our measurements on the other leg. And we wanted that to match with the nail ending at the place where we had made our chosen measurement on the other leg. We used a 400 millimeter nail for this, 10 millimeters in diameter to be, 11 millimeters in this one to be stiff enough for the patient to ambulate on. And if we chose our distal and our proximal ending points of the nail correctly and put a 400 millimeter nail in, we should make the leg the same length as the other one. Here in this image, you can see that we were bending some of these K-wires pretty hard because we were pulling on them very hard in order to align this distal segment and prevent it wanted to fall into a valgus alignment. So we were pulling on it in order to hold it so that it looked like the nail was going right up in between these two cortices here. That's how we know that we're in the correct alignment, because we're splitting the uprights perfect. So if we're going straight up the middle and we're going straight up the middle of the rest of the bone, then the bone should be straight. Here we are putting some distal interlocking screws in place. We put 2 in just with drill bits in order to hold it stable, while we then put in a third in an oblique fashion. After that, we ended up putting, I think I have another image showing that we eventually put this last screw in here. We stabilized with our interlocks, and then we did one final rotational profile here. We have a perfect lateral view of the distal femur. We get an AP of the hip, and we've confirmed that our lesser trochanteric profile matches that of the other side. And then we put a drill bit across it to lock the rotation. Then we lock it up with a screw. That right there is just out of out of order. Sorry, guys. And then we stabilized our articular block more with this second cannulated screw. So you can see we've bridged our comminuted segment, and we put our bone in a correct alignment, and we think to the best of our ability that we've put in the correct length and the correct rotation. But we don't really know that. We just gave it our best shot. So how'd we do? In these cases, when we really don't know and we did our best, but it could have been completely off, we typically will get a scanogram afterwards. And a scanogram is a CT-based image that can image the entire bone. And on a CT, you can very critically and very carefully assess the rotation, and you can also assess length. So we get a scout image and we look at the intact femur, measuring from the very top of the femoral head to the very bottom of the medial femoral condyle was 45.3 centimeters on the intact side. And we put this patient at 45.9 centimeters on the injured side. Within 1 centimeter, basically at 1/2 of a centimeter. So I think we did pretty good there. How do we do on the rotation? So this is how a scanogram typically looks. You get select cuts through the femoral neck, and you get select CT cuts through the knee. And what we can do based on that is we can draw a perfect horizontal line on each image, and then we can draw a line that, to the best of our ability, shows us the axis of the part of the bone we're looking at. So on the intact side, we have 20 degrees of external rotation of the femoral neck relative to the horizontal plane. And the distal femur, we have 14 degrees of external rotation of the femoral condyles relative to the horizontal plane. On our injured side, our measurements are 16.7 and 6.6. So how do we do this in our head? So if we have 20 degrees of external rotation of the proximal segment and 14 degrees of external rotation of the distal segment, what I do is, in my mind, I pretend that I can align these femoral condyles flat on the floor. And in order to do that, I would have to internally rotate it 14 degrees. And if I have to internally rotate this 14 degrees and this bone is intact, that means the proximal segment internally rotates 14 degrees. So I made this 0, and I made this one 6 degrees just by subtraction. So then we do the same thing on the other side. And what we wind up with is our intact femur. The patient's normal anatomy has 6 degrees of anaversion. And on the injured side, we put him at 10 degrees of anaversion. So most of the literature that we look at supports the notion that if you put someone within 15 degrees of the normal side, they will probably tolerate it okay. So I think here we put him right at 4 degrees off from his normal side. So we're pretty happy with that. That was a lot to go over. What sort of questions could we answer?
Just a quick point to either Joe or Jeff. In my case, I had 2 proximal interlock screws and 1 distal. In Joe's case, he had 3 distal interlocks, maybe one or one, just one proximal. Why are we doing different interlock screws?
So where you place, so in all nails, 1 screw is required on both sides of the fracture at a minimum, because the screw locks in the rotation that you have selected. So that's a minimum. If you're asking the screw, you're selecting the screw's only job is to maintain rotation, then that's all you need, theoretically. So in Jeremy's case, he had a fracture that was transverse. So the 2 ends of the bone could line up with one another and stand on top of each other like Coke cans. So it's axially or length stable. So you're not asking the screws to hold the bone out to length. So then you're asking the screws to hold rotation, but are we asking the screws to hold the bone from falling into varus or valgus or procurvatum or recurvatum? And depending on where that fracture is and how cone-like shaped the medullary canal versus how straight like a pipe it is and how well it hugs the nail, that's what's going to determine how much angular stability you're asking those screws to do. Does that make sense? I don't know if I'm describing that well enough. So if you had a fracture that's right in the mid aspect of the shaft, that's a lot to go through. I don't know if I'll find it. Here, this fracture is not in the middle of the shaft. It's a little proximal, but we have a good, pretty straight cortex on one side of the nail. And on the other side, it's straight until right about here. And then it looks like it starts to peel away from the nail. On the other side, it's pretty straight, flush against the nail, pretty far until about here on both sides. So what in your mind you're asking is this far and this far enough of a straight pipe to hug that nail and prevent it from angulating? And the answer that we typically go with is whichever side of the bone is shorter, we'll usually get a second screw to add angular stability. And whichever side has the most bone hugging it could probably get away with just one screw. 2 screws isn't necessarily wrong, but probably not needed. In the example that I gave, we were asking a lot of these screws. These screws had to not only hold the rotation of the bone, they also had to keep this fragment from tipping into varus or valgus or procurvatum or recurvatum. And then also, none of this bone in between helps us maintain length. Not one bit. So we're also asking these screws to support the full weight of the patient. So putting 3 screws in here gives us a lot more stability and security, especially given the fact that we know this bone has cracks that run through it. And up here, well, this screw is a long, long ways from the fracture, and we have a lot of straight, good bone between us and the fracture.
Yeah. And then Mina asked before, do we commonly encounter any ligamentous knee injuries in conjunction with femur fractures? Mina, I'm going to propose this back to you. So in femur fractures, a lot of these are in motor vehicle crashes. When the patient gets in the MVC, where's their leg hitting into? What's causing the femur fracture?
Isn't it just like the impact into like the I don't know, like the dashboard? Like,
yeah, it's commonly dashboard injuries. So it either fractures through the femur or the dashboard can hit the tibia. If the tibia gets hit, what do you think is going to cause, which way is the tibia going to go in reference to the femur?
Gonna go posteriorly.
Yeah. And so if there's not a fracture, do you think there's any ligamentous injury or a certain ligament that can be injured in that case?
Yeah, you can get a PCL injury.
Exactly. So a lot of the times these patients have PCL or other ligamentous injuries. And in the trauma bay, initially when you're seeing them before fixation, it's hard to assess that, because if you have a femur fracture, the femur is going to be floppy. It's hard to get a good knee examination. You're not going to be able to do anterior posterior drawer, Lockman's. So once you fix the fracture, it's very important to assess for ligamentous injury in the operating room. So you can just do that either with just a general knee exam, or you can use fluoro since you have it and check for any subluxation of your tibia in reference to the femur. So that's a great point to bring up. Once you fix the femur, you should check that. You should also check the femoral neck. we talked about getting a CT scan earlier about assessing for femoral neck fractures, but even if you see a negative CT scan for femoral neck fractures, you should still fluoro the neck, do internal, external rotation of the femoral neck to look for any femoral neck fracture, because there's a still small percentage of patients that get negative CT scans, but there's still a femoral neck that's missed. So that's the patient you don't want to miss that. And then another question here, if you guys want to answer it. After stabilizing the interarticular fracture with screws, is there any risk of it becoming displaced during the reaming/nail placement? And if so, would that risk be higher with the antegrade approach?
So
I'll take this one.
Yeah, sure.
So if you're looking at the intra-articular fracture, yes, there definitely is a risk of displacing it while you're doing the reaming and the placing your nail. But keep in mind, looking at this final construct that we put in addition to our free screws that are outside the nail that are essentially performing our primary stabilization of the articular fragment. Additionally, the interlocking screws that are going through the nail are also stabilizing our distal block, femoral block. If you think about this as a antegrade approach, when you have your nail that is getting seated, it wouldn't be able to go as far down as distally as you can see on this antegrade nail. You'd be stopped more by the more in the distal femur, and additionally, you'd only have 2, possibly 3, depending on the implant interlocks that are placed distally, but not allowing you to stabilize the fracture block as sufficiently as you are in this case. Additionally, just as Joe mentioned, when you're talking about the conical shape of the distal femur, the medullary canal, a retrograde nail in this case helps you achieve your overall alignment more appropriately and more adequately than if you're trying to use an antegrade nail.
Like, can I ask a quick question? Like when you have patients with like the pelvic fractures, do you have to put them in a pelvic binder right away? Because I had a question on an exam recently, and that was like the answer choice, just because of like the huge compartment with all the like major blood vessels. Like, did you have to do this in the case of this patient?
So this patient did get a pelvic sheet. The indications for putting a pelvic sheet on are a patient who has an expanded volume pelvic fracture who is exhibiting hemodynamic instability. So sometimes what we find is that people will put, emergency providers or the general trauma surgical team will put an emergent sheet on a pelvis when a patient is hypotensive, they have a pelvic fracture, put a sheet on it, see if it helps. That's probably fine most of the time and not necessarily causing more damage, but there are certain pelvic fracture patterns where it's probably not actually helping. Maybe it's hurting, maybe not, but it's probably not helping. The important thing that a sheet does is, I don't know if you guys can just see the screen or if you can see my screen, I'll just demonstrate with my hands. If you were to think of the pelvis as a ring, and my thumbs are the posterior, the sacral elements, and the sacroiliac joints, and that you had a anterior posterior compression type fracture where the pelvis opens and it's swinging open on the hinges, then you're going from a closed container that can hold like 1.5 liters of blood to a limitless volume container that could hold the patient's entire blood volume. And if they have an arterial or significant venous bleed into this limitless volume pelvis, then closing down that volume with a pelvic sheet could save their life. if their injury to their pelvis was an internal rotation where it went this way, well, the volume of the pelvis got smaller, not larger. They can have a bleed, but they don't have a limitless volume pelvis. So putting a sheet on in that instance isn't just an automatic. Now, if the patient's hemodynamically unstable and they're just dying in front of you, putting a sheet on is not the wrong thing, but it's probably not going to help.
Thank you.
All right. Any last questions?
I kind of have a question. I was just wondering, like, what do you tell a patient like this in terms of their time course for healing?
Yeah, it's a great question.
Because this seems like a pretty severe injury. I don't know if it would be different.
I'm happy to take that question if no one else wants it.
Go ahead.
So we know about the timeline of certain bones and how long they take to heal. And then you know that worse injuries you could expect to take longer than a routine injury. And we know that femurs heal really well and really fast. Tibias take about 18 to 20 weeks to heal. A femur can usually heal a little faster than that, closer to like 15 weeks before it's gaining some union. This one I would expect is going to take a lot longer, but in terms of, that's not what a patient cares about. They don't care about when does my bone look like it's healed. What they care about is when is my, number one, when am I going to walk again? Am I going to walk again? Number two, when is my pain going to go away? Number three, when can I return to normal life? Those are the sort of things that they're trying to answer in their own head. And for this particular patient, we have a complex of injuries, and you have to take the largest denominator. If on his femur he could walk, let's say immediately, well, then that's fine, but can he walk on his pelvis immediately? And the answer is no. So for each side of his pelvis, we would restrict this patient to 30-pound weight bearing on each side. So that's the least common denominator. So that's what he's left with. And I actually have to step back. That's not his least common denominator. He had an articular injury to his distal femur. So for this patient, we would make him non-weight bearing on his left side. Classically for up to 12 weeks, but if it's going well, probably could let him weight bear a little bit sooner. His pain should go away a long time before that, probably on the order of 6 weeks. He would have a significant reduction in his pain, if not down to nothing other than stiffness. But he's going to have a long road of recovery ahead of him. After he can be putting weight on his legs after 12 weeks, he's going to need significant physical therapy. He's going to have muscular weakness. He's going to need rebuilding of his coordination and his gait and balance. So it's typically for a patient like this going to be a full year before they're back to a full functional recovery, and could be longer depending on how motivated they are in physical therapy.
Okay, thank you.
Oh, wait, one more quick thing before we leave. Like in our, like a lot of the board exams, they always give this scenario for like fat embolus, like a femur fracture. Is that like actually accurate in like real life? Like, do you monitor them for that, or you see it a lot? Like a fat embolus?
Don't see it a lot, but we do see it. It's a real thing. Yeah.
Okay.
I mean, personally, I've never seen one. But yeah, I've seen it on tests.
I've never seen one either.
So,
but that being said, we do see ARDS with, polytraumatic patients, and maybe we do contribute to some type of lung injury with us doing, some type of femoral procedures rather soon rather than waiting. Because if we got into a lecture on damage control orthopedics, it's about doing stuff to the patient when they're optimized for surgery. So you don't want to do it too soon to affect their overall, care.
We do know that every time we jam a volume displacing object down the canal of a long bone, we displace the marrow. Where it goes when we displace it is, just up to physics. It either leaks out through the fracture, or it, makes it into the lymphatic system somehow, or into a blood vessel. 99% of it goes out the fracture because that's the lowest pressure environment, instead of being squished into the patient's blood system. Okay. Well, thanks for signing on, guys.
Yeah. Once again, if you guys have any topics you want us to discuss, just let us know. We'll try to do it every other week. And follow us on Instagram, njms.orthopedics. We're going to be trying to do some more case-based presentations and stuff on that, and some questions relating to these lectures. Also, I don't know if Joe Ippolito sent out an email about this, but next week.
Not yet.
Joe, you want to talk about it next Thursday?
No, you can go ahead, Jeremy. I just didn't send the email out yet.
All right. Well, next Thursday, September 24th. So every month we've been having a trauma journal club where we meet at one of our attendings country clubs, and we have a bunch of cocktails, great meals, some great desserts, and then we go over usually 6 to 8 different trauma journals, and we discuss those. So we're going to be inviting all medical students to join that. And then also at the same time, we're going to be doing a residency Q&A where a bunch of our residents are going to be on there, where you guys can ask us questions about the residency program and just get to know more of our residents. Because I know this time is unprecedented times for interviews and whatnot. So we just want to get you guys a little bit more familiar with our program. So that'll be next Thursday at 7 p.m. Everybody's welcome to join. I don't know, Joe, do you have any more to add?
No, I think that was perfect. I'll try to send something out tomorrow. Spread the word. We'll post some stuff on Instagram as well. Should be fun. Get a look at some of the background behind the scenes stuff of us just having fun with circuit and our attendings. So
maybe you guys can catch me on the golf course beforehand. All right. Thanks again for joining. We'll see you guys in 2 weeks, or next Thursday if you guys want to join.
Thank you, guys.
Thank you.
Thank you.